Well, let's take a few minutes now to go over any questions. Any questions from the audience in the meantime? Until we get the written ones? Yes?
Are there some statins that are better than others?
Mike?
Yeah. So yes, the two that have the best data for safety and the best data for working are both the same meds. So atorvastatin, which used to be Lipitor, and rosuvastatin, which used to be Crestor. Both of them are generic, and so the recent studies have been with generic medications, and so there's not a lot of pharmaceutical influence anymore, and despite that, the results have been exactly the same. So those two seem to be the best two meds that we have.
Does that drug make your muscles ache more or get tired? Oh, I'm sorry.
Yeah.
Does your statin drug make you get tired easier?
So this is the danger of all of prevention in 10 minutes. It's much more complicated than what I presented. Like I said, after that first statin was a bad drug, ever since then there's been a lot of concern about the new statins causing problems. In the trials, we haven't been able to figure out what it is about the statin that would cause people to be tired or cause people to be achy. In the trials, the rate of muscle aches tend to be the same between both groups. That being said, we have a lot of patients that start their statin and say, boy, I just don't feel very well on it, and they stop it and they feel better. If we were to add all the data together, by my account, I think for every 100 people we give a statin, 80 of them are going to tolerate it fine, and their cholesterol will come way down. 20 people are going to come back into clinic with a complaint. Of those 20, in at least 15 or so, it's probably not the statin. And 3 or 4 it probably is, and we don't have a test to figure out if it's the statin or not. And that makes it really hard. So it's a really complicated situation. There's no situation where a patient comes in and says, I'm feeling terrible, and I say, oh, just keep taking it, you're fine. That's not the situation. We want you to feel good.
They'll never come back at you, bro.
That's true. And so we take each patient seriously, and we evaluate each situation differently. By most accounts, like I said, they're safe for the most part.
Okay. One question from there.
Could you please tell me how long does a stent last? Sorry.
Santiago, you want to?
Yeah, sure. It depends. So the stents last forever. They stay with you the rest of your life. We don't take them out once we put them in. The question I guess you're trying to ask is, if I'm going to have scar tissue formation within the stent, how likely that is to happen and when is it going to happen? With the medicated stents, I think in general in the trials we see that happening in single digits. It's less than 10% unless you have diabetes. If you have diabetes, that tends to happen more often. In general, about 10 to 20% of the stent will form a scar tissue. And in those situations, we may decide to put another stent inside it or do something like brachytherapy, or sometimes we do bypass surgery. But the stent will not be removed. It will still be in that artery. So I would say the overwhelming majority of stents perform very, very well for decades.
Great. Yes, sir.
What happened to Johnson & Johnson?
Oh, bad marketing.
You mean the Cypher stents?
Yes.
Well, Cypher stents had the worst outcomes. Then it was the very first, but then also the least, had a lot of side effects, issues with the polymer, the drug. So the next generation stents were much better, and somehow they failed to keep up with the evolution of stents. I mean, I don't know if you guys, but essentially their stent was good to start with, but then better stents came along.
They're back again, though, and they're trying it again. And I just think they made some bad business decisions.
Yeah.
One more question that came up is about why would someone be kept on 324 versus 81 milligrams of aspirin? I don't know who wants to take that one.
Yeah.
Sure.
Can we get one of the microphones maybe here?
That question was, what's the difference between baby aspirin and full-dose aspirin? And the answer to that question is that we don't know. We don't know that answer. What it looks like so far, 325 and 81 milligrams has the same, we believe, the same effect on your blood. The difference probably is in terms of gastrointestinal side effects. So for the most part, we recommend 81 milligrams, and that's a very, very European thing. You know, we did sort of the American thing, well, more must be better, and it may not be. We're actually participating in a large multi-center trial looking at this very question, but for the most part, 81 milligrams is safe, and certainly if you're on additional blood thinning medications such as Plavix or one of the others, or Coumadin or something like that, 81 is probably safer.
Doctors? Doctors, can you hear me?
Yep. Yeah.
I have two questions. How many stents can be installed in exactly the same area, number one? And number two, would the board be kind enough to explain a heart bypass in this day of modern technology?
Well, I'll take the first one, and that's how many stents can you put in one place. We don't actually know the answer to that question either. We know that if you have a problem with the stent the first time, the best procedure to have is another stent. After two stents in the same place, it looks like a third stent is probably not our best bet, and we may do something like intracoronary brachytherapy, which is intracoronary radioactive therapy. Now that's pretty unusual. We don't see the need for that to happen is very uncommon. Occasionally we'll get up to 3, and I know people have done 4, but basically at that point, you know, we're talking about bypass surgery or, you know, kind of giving up the ghost. Because we can't cure everything. Would somebody else like to talk a little bit about bypass quickly?
So I think you get the picture of what we do with the stents. We don't remove the cholesterol. We push it to the side. And when it grows back inside the stent, oftentimes we think about, well, can we change the natural history of the disease? So bypass is essentially a way of giving you new blood vessels. And the surgeons will typically use one of your own vessels called the mammary artery down and put in the front vessel by essentially attaching it using sutures. And then they will take veins from your legs. And those veins essentially are attached one proximal to the aorta, which is the main vessel coming off the heart. And then the distal segment of that vein will go beyond the blockage. So now you essentially are bypassing the blockage. So you don't have to worry about pushing the cholesterol to the side. You're attaching that bypass to a segment that is normal, that is beyond the blockage. Now, veins are not arteries, and they don't last forever. They are not designed to tolerate the levels of blood pressure that we have on the arterial side. So the same issue that we have with the stents, which at times they form scar tissue, may happen to a vein. And the number that has been quoted for many, many years based on the studies is there is about a 50% failure rate at 10 years when you have a vein as part of your bypass. And in those situations, oftentimes, then we put a stent inside the vein or try to be creative and open up your own vessel again. So it's not the end of the road, but it is, it's a way to increase longevity.
Yeah, we'll cover this also in one of the upcoming talks. I think maybe one last question, and then we'll go to the next part, and then we'll have more questions at the end. Oh, sorry, yes.
Yes, actually, a quick follow-up on Dr. Garcia. Were you saying you always use veins in a bypass?
I don't do bypass, but the surgeons almost always use veins as part of the strategy. We don't send people for bypass when they have just one blockage. Mm-hmm. In general, we treat those patients with the stents. When you send them to the operating room, is because they have multiple blockages. The typical operation will be one artery and 2 veins. Now, surgeons are getting more creative and using more and more arteries. And we are, it's being studied whether arteries are better than veins. They may take your radial artery from the wrist and use that as a conduit. But yes, veins are usually part of a strategy.
And my initial question was about the last presentation on the coronary calcium scoring, which sounded like a great thing. And I'm just wondering why it isn't being, I'd like to have one. Why isn't it being done routinely?
That's a great question, and I also would like to hear Mike's Mirima. The evidence, I think you have to see from two perspectives. One was that a lot of hype about, doing CAT scans, and now we have a great toy. And the evidence was a little bit behind. Now we look at 2019, we have studies over studies showing that the best way to define one's risk and be personalized the medications to one is to look at that CAT scan. Some insurance companies are actually adopting that, but it's not a wide across. Here we offer heart scan for $99. I think it's the best investment, actually best Christmas gift that you could give it to somebody, is to know, what the risk is and hopefully modify that. But any thoughts about insurance?
Yeah, I think one of the issues is that the marketing was ahead of the research. When it came out, it looked like, it was intuitive. It made sense. So I want to see if I have plaque in my arteries without a lot of research to back it up. And so there was a number of editorials written in the late 90s, early 2000s saying, hey, we have all these people getting these heart scans. What do they mean? We don't know what they mean. So it kind of got a black eye for a while. And now the data's come out in the last decade or so. It turns out it works quite well. It's a good test.
Great. So we'll move on to the next presentation. The last question was about why not take statins without a CAT scan, and the answer is yes. In high-risk patients, even on risk factors, statins remain the mainstay. So you don't have to get a CAT scan to get a statin. Just to make sure. That was phenomenal. Thank you so much. Are there any questions? I know that you've now been over a couple hours here. Any questions at all? And you can know. Yes, sir.
My wife is a cardiologist nurse, cardiac nurse. I had stents put in, 4 stents 5 years ago, and I see my cardiologist like every 9 months and take meds and we tweak them. But my wife tells me I have heart disease. Now, my mindset is I've been treated for heart disease. Do I still have heart disease?
Yeah, unfortunately, it's one of the things, once you get it for life, it stays with you. Having said that, there is something active and, something that you've had, you have to know about it, but you don't have an active disease, like you have the stents, right? So that means you had the coronary blockages, you got the stents, and you're still at a risk of developing more blockages, but you can do many things and hopefully never need anything else done. So you do have heart disease, but doesn't mean you're going to have a problem again, necessarily.
Yeah. So in terms of risk factors for having an event, one of the main risk factors is having had a prior event. And so we talk about primary and secondary prevention. Secondary prevention is if you've had one event, now you're trying to avoid a second one. Doesn't mean that's not treatable. It just means that you're at enough risk where we should pay attention to it.
My question about my husband is, he wants to climb mountains, say, 10 to 12,000 feet. Should he be doing this with 4 stents?
I wonder who planted that idea.
Why not? No brainer.
I think we typically look at what's the risk of doing it and what's the risk of not doing it. And 40 years ago in cardiology, the main treatment was to rest and take it easy and just don't ever stress your heart out again. And the people that ignored that tend to do better. And so there's risk in climbing a mountain at 10,000 feet. There's also risk in shutting things down. And so if it's something that you really enjoy and something you want to try, as long as you take it steady, I don't think it's a hugely high-risk situation.
And I guess the point is, if you don't climb a steps of stairs every year, you don't want to go 10,000 feet, right? As long as you're active now, you're exercising, and you feel in good shape, then absolutely. If you are not, you first exercise here, get in good shape, and then you can do the things that Dr. Herman was doing. So common sense, there's nothing magic to it. But having had a stent, the goal of a stent is to give you your full life back. Do whatever you want. That's the goal. Yes?
What is a stent made of?
Excellent question. The question was, what is the stent made of? And most of the stents we currently use are made of an alloy called cobalt chromium. And these are essentially, it's a metal that is fairly resistant to deformation. And then have a drug on them, as Dr. Garcia showed, there's a drug that covers them.
For those of you who want to see one, we have a few here, so stop by the table and I'll show you one.
the stents start having the drug in them?
About 2004 is when they were released in about 2004 for use, widespread use.
So do you think in 2008 most of the stents had that or
most
not?
Most of them, yes.
What's the relationship between inflammation and cardiac disease? Since you talked about C-reactive protein, and I'm just wondering, patients with colitis, other things, what is that relationship? I don't understand.
Yeah, that's a really good question. It's a little bit complicated, but we know that part of the plaque process is an inflammatory process. The more inflammation there is, the more the plaques are the more they're unstable, so the less stable that they are. And so we know that chronic inflammatory diseases do increase your risk for having cardiovascular events. Now, checking cardiovascular inflammatory markers as a way of assessing your risk isn't super helpful. There's a ton of people with high CRPs that don't ever have events, and there's a lot of people with normal CRPs that have events. And so again, it's the question of, we know that inflammation is a really important part of that process. There's been a couple trials looking at anti-inflammatory interventions to reduce risk, kind of with mixed results. And there recently was a trial of people out in Brazil. It was one of the kind of tribes that's way deep in the Amazon that they don't get a lot of medical care and don't have a lot of outside exposure. And they went there, and their people in their 70s and 80s have incredibly low calcium levels on their calcium scores. They're mostly free of cardiovascular disease, and their inflammatory levels are all through the roof because they constantly have foot infections and leg infections and other things. And so it's not a direct correlation. It's a much more complex relationship than what we think.
When you do a bypass, you take a vein out of the leg and one out of the chest, right? So the one out of the chest, is that also a vein? That's an artery.
Yeah, I think what they describe is the artery inside the chest called the lima. That's the one they use in most bypasses. That's the one that stays open for the longest. The rest comes from the leg, from a vein from the leg, and these are the ones that are more likely to re-narrow and get in trouble down the line.
That's never failed, the one in the chest.
It is amazing how nature. It is amazing how the anatomy was so well designed by somebody that must be above us here. Because when you dissect that lima, the left anterior memory artery, it falls right into the widowmaker. It falls right into the LAD. So it's almost, it was made out of to serve as a bypass graft. And, we see patients sometimes that have had bypass surgeries 10, 15 years. They have had that lima. Sometimes they usually use the right side, the rima, the right intramemory artery. But when you see bypass grafts from the lima and from the leg, sometimes the leg ones are all occluded, and all the other vessels look bad, but that lima is still providing blood flow for everybody. It's such a high flow, system, and it stays open. It's probably the last one.
I mean, it's not perfect. If a cardiologist actually said that was apocryphal. It's not true. They do fail, but they fail very rarely. And if you have bypass surgery, you really, really want a lima graft at the time of the surgery.
This is a question I asked earlier privately, but it's one that is a commonly held belief. I had a metal stent put in 17 years ago, and one of the understood things I had been told was that I should never have an MRI. I'm told now that that has changed. If so, it would be good to get that information out there.
Yeah, that's a great question, and that's a misbelief. Actually, a lot of all devices, valves in the heart, except for very old ones from 1967, 69, are unsafe, but majority heart devices, stents, whether stents in the brain, in the heart, in the lungs, in the legs, they're all safe for MRI. They might produce a little bit of some artifact, but they're still valuable to be studied. So I appreciate the question, and I think that's definitely should be spread out.
Yes, just to reemphasize that calcium screening, which I think is a great idea. I had, last spring I was 73 and had a couple of stents put in, Dr. Brooke, that DK procedure. And My calcium score 6 months before the problem started was 0. And so if you have a high calcium score, you definitely have a problem. But if you have a low calcium score, to reemphasize, you may or may not. It just means you have no calcium.
That gets to the purpose of the test. You know, the calcium score is meant for asymptomatic patients who want to assess their risk. If you're having symptoms, the calcium score is not the right answer. If you're asymptomatic and are wanting to assess your risk, that's where the calcium score is ideal. We do see events in people that have scores of 0. It's just the event rates are very, very low.
And so, you know, as the risk of the non-calcified plaque, and particularly in the young population that would not have enough time to calcify that plaque. So it's not a good test, as Dr. Miedemann said, if you're having symptoms. You need to use with the contrast, the CAT scan.
Is there a difference between plaque within an artery and plaque outside the artery? Is that possible?
Yeah, you know, the plaque is on the wall, and then initially, actually, the artery grows on the outside. The body kind of tries to preserve the lumen of the artery, that the blood can flow, but eventually it's so much that it actually starts closing down on the lumen where the blood is flowing through. So you always have plaque on the wall of the artery. Sometimes it doesn't really make the lumen narrow, but eventually it will. Okay?
When do you do a CAT scan, and when do you know whether to do an MRI, and what is the difference between the two?
Very good question. So CAT scan versus MRI. So the CAT, it depends again what is the question. So MRIs can also look at, MRIs can be used for stress testing. So if somebody has symptoms and you wanted to see if there is a blood flow problem, you can do a stress MRI. And if there is not enough problem and not enough blood flow, you will see that this MRI is going to be positive. A CAT scan can also be used for detecting the blockage. So if somebody has symptoms, I would argue, although I wear the two hats at Minneapolis Heart Institute, I would argue that actually the CAT scan might be a better test. Because it's most of the time somebody has symptoms, most of the time actually you don't find blockages, you find lumps and bumps. And that's the opportunity that over time, by putting them on the right medications, you will prevent heart attacks from happening. There are 2 large studies that have been published recently, one from the United States, another one from Scotland, that have shown that actually the best test perhaps could be a coronary CT scan with contrast, not the calcium scoring. You will see plaques, and that's the time that you might have to start them on cholesterol medication. So MRI is good for stress testing, but MRI does not see well the vessels. To see the vessel, you need a CAT scan.
Okay, perfect.
Doctors, I have one for you. Back in 1989, I had 4 balloonings before they even discovered stents. And the balloonings lasted 27 years. So then time went on, and I had to visit you folks down at MHI, and you put in 4 stents in those same areas that were ballooned. Guess what? 11 months later, my primary care cardiologist would not believe that that stent got plugged, and I had to go in again and get another stent after 11 months. What did I do wrong?
Nothing. You did nothing wrong. Actually, that's the story of the first patient who was ever treated with this technology. Dr. Grunstedt performed a first balloon angioplasty, and it lasted over 20 years. And then he got a coated stent in another vessel that lasted 1 or 2 years. That is the exception, is not the rule. And I think an explanation for what happened to you is that by the time you needed a stent, there was a scar tissue already in that vessel. So the difference is not so much that we're comparing balloon versus a stent. You're comparing a lesion that already had formed scar tissue inside it. And therefore the second therapy was less durable. All the trials that we have done, in general, we like to compare apples with apples. And when we compare arteries that have not been treated before, stents are better than balloons. And that has been shown in multiple trials.
I think the other thing about this is that, remember, we're trying to predict the future.
And I've got a lot of smart partners who use amazing technologies to try to predict the future. But if I was able to predict the future, I'd be sitting on my island waving at you people and not letting you on it. So we're imperfect at best to doing that. And there's always the person that has the exact opposite, response. The person who doesn't get their cancer treated and it somehow regresses. And then that sort of thing. And that's why, because of things like this, it's important that we not treat our patients based on the last patient that we saw or what our neighbor had to say. But what we actually do is try our very, very, very best to use the best scientific data that we can to help treat the next patient comes through the door. Because the best we can come towards predicting the future is using statistics and these research protocols. And that's the beauty of working at a place like the Minneapolis Heart Institute, where everyone sitting here on this panel is participating in the absolute cutting edge therapies. And these people are world experts in what they do. And I'm just really, really thrilled and extremely lucky to practice with these people.
I think that end. Maybe we should stop here, I think. Maybe one more question, because can delay. Maybe one more question, and then we'll...
Could you tell me, a lot of times doctors will just ask if heart disease runs in your family. Is there a genetic factor there?
Yeah, so in terms of risk, family history is clearly a risk factor. The most potent type of family history is a family history of premature heart disease, so an event in a family member less than 60. Typically, it's a first-degree relative, so your parents or a sibling kind of carries the most weight. Aunts and uncles don't carry as much weight. It's interesting, though, if you look at family history like in these risk equations where they try and add all these things together, it's often not included, and that's because once you account for traditional risk factors, the family history risk often goes away. So meaning that most family histories are mediated through either cholesterol or through blood pressure or through smoking. And if you address that risk factor, then the family history risk isn't as potent as what you think. And so if you have a family history of heart disease because they all had high cholesterol, if you treat the cholesterol, the family history risk can go away for the most part.
All right, okay, and one more?
I'm wondering, I've heard that sugar causes inflammation. Is there anything true to that about?
Yeah, so like I said, nutritional research is really complicated, and we are in the era with the internet of a lot of food fads and a lot of kind of hot topics. And so right now we should say you should definitely eat coconut oil because you're going to live forever. And last year it was pomegranate juice, and next year it'll be something else. And so right now one of the villains is sugar, and there's a fair amount of truth to it. One of the best ways for your body to build fat cells and to build up fat is to take in sugar. And the issue is that a little bit of sugar isn't so bad for us, but over the last 2 decades, the amount of sugar that we consume in the U.S. is drastically increased. And that is probably one of the main causes of our obesity epidemic. And as you build more fat cells, you tend to get more inflammation, and inflammation has some cardiovascular risks associated with it. And so sometimes we can take that too far. If you go on the internet now, there's all these anti-inflammatory diets that are going to decrease all the inflammation in your body, and they'll say it's not cholesterol, it's not blood pressure, it's all inflammation. That's an overstatement. That being said, a lot of these anti-inflammatory diets are more fruits and more vegetables and more kind of healthy foods, and so there's nothing wrong with that.
Well, again, I would like to thank you all for coming tonight. I would like to thank our patient, Dr. Herman, for the story, the MHIF staff, Maya and Bhavana, for organizing the event, and the rest of the MHIF staff, and all the faculty. So thank you so much. And if you want to see a stent in action, Dr. Garcia will show one in a few minutes. Thank you again, and good night.
And thank to our speakers, Stu, for